I'm Dr. Jim Lyon. I'm an interventional radiologist with San Diego Imaging Medical Group. We're here at Sharp Memorial Hospital in San Diego. I'm going to demonstrate a cryoablation case using the Endocare Cryocare system. I'm very familiar with that unit. I've used it for about 8 years now. This is a 68-year-old gentleman who presented with gross hematuria. CT scan showed largely exophytic mass from the interpolar right kidney. Its maximum dimensions are about 25 by 25 by 35 millimeters. Its long axis is not particularly favorable today, so we're going to have to use 3 or 4 probes going forward. That remains to be seen. Comorbidities with this gentleman include atrial fibrillation. He's on Pradaxa, which he stopped for 3 days for this procedure, and he has coronary artery disease. He received a coronary stent about 3 or 4 years ago. Other than that, he's healthy and good to go. So let's get started. So these are initial non-contrast images, just localizing images, low dose. And here we can see the target tumor. From this set of images, we'll pick our table levels going above and below, give contrast, and help define the inner margins of this, which will be key in terms of defining its size and ablating it correctly. So these are the contrast images, and we can see the lesion with much better conspicuity. Unfortunately, the long axis of this lesion is not favorable for us today, but we'll still be able to handle it. We'll go into that more as we go. Right now we need to pick our table levels, which we're not seeing on this annotated or anonymized protected image, but we'll choose our levels and come back. Okay, so here we've taken our localizing images. This would be the approach we'll take. Again, it's across the long axis rather than down the long axis. This will be our approach to our guide needle, which is our biopsy needle as well. So we're back at the patient's side here. These are the fiducials that we've put down to mark our level. I've determined that this is the path we'll take. So we'll go ahead and clean him up. Michelle, can you pop these BBs off? Thanks. So we're going to biopsy this lesion before we treat it. There's a 70 to 80% chance statistically that this is a cancer, and I always give people the option of biopsying at a separate setting and coming to treatment only if it's malignant versus doing it all at one setting. And people tend to choose the one setting. I'm more in favor of that myself, given the sort of the vagaries of benign biopsy with the chromophobe adenoma. It's worked out well. You know, initially I thought maybe the biopsy might lead to some bleeding that would obscure the site. That hasn't been a problem at all. And actually, of the first 2 of the first 3 that we biopsied were benign, which was surprising. Haven't had a benign one since then, which is a long time ago. We're going to scan right here 3 sections. So we're going to just advance this. So our guiding needle of our biopsy is in place. We'll take a couple of biopsies there, and we'll leave that needle as a guide for our probes. So we're back with the patient. We're going to take our biopsy. The guide needle was a little deep. I'll just pull it back. Take a few 20 gauge cores here. Drop them right in the formalin. Looks like a nice core. I'll bias this needle caudally and take a biopsy. And biopsy in a more cephalic direction. I don't skip on the biopsies. Again, I mentioned the chromophobe adenoma, the oncocytoma controversy. Pathologists tell me that those tumors can actually have benign versus malignant centers and can be very hard. So It would be wonderful for this guy if at the end of the day this proves to be a benign tumor. Again, statistically very unlikely. But while we're here, no reason to skimp on the biopsies. Okay, let's get a Perc 24 out and we'll test it. Michelle's going to hook the probe into the front of the machine. Which port are you choosing?
1.
And I'll mark this probe as number 1. We've got the probe in our saline. So when you test a probe, you're out to see that it freezes appropriately, and you're also out to blow any particulate material which may or may not be in there. So it's a 90-second helium thaw cycle. Again, you're looking for bubbles and you're just waiting at least 90 seconds to purge the probe. And then the argon cycle is at least 30 seconds. You're looking to make sure that you don't have bubbles, you're looking to make sure that you have ice, and you don't want to see frost coming up the shaft. Frost up the shaft or bubbles would indicate a faulty probe. Never seen it. We've got the probe in our saline bath here, and we're going to hit thaw. So we're going to hit the thaw cycle here for this first probe. That's going to throw helium through the system. The idea of there is there any microparticles in the system that it would blow it out. If there were a microparticle there and you hit it with the argon cycle, it could create an ice block. Never witnessed that, but we always blow the probes out. Also, we're looking for bubbles. If this probe is damaged in any way, there would be bubbles. I've never seen that. We do this helium cycle for 90 seconds.
90 seconds and I will freeze.
So we're at 90 seconds now. The probe is tested well. We're going to hit the freeze cycle. The monitor is starting to form an ice ball now. The monitor should show minus 20 degrees by 20 seconds as a rough mark or measure of probe success. I've never seen it not work that way. See the ice ball forming on the end of this probe. We go for 30 seconds.
We're at 50.
Okay, so now we'll thaw this. Thaw. So, Michelle, let's get another probe and we'll get that one going. So, based upon this marker needle and the need for 2 probes in the center of this, I want one of my probes to be medial and one of my probes to be lateral. We'll put guide needles in. This is just a hypodermic. And I also happen to have a spinal needle here. We'll pass these parallel to the probe. We'll repeat our 3 images. Those 3 images, of course, are one at, one above, and one below, a typical so-called Z formatting of the manufacturer, CT manufacturer. So we'll get our second probe out here and get its up and running. So our marker needles are in place along with the guide needle. I like the medial marker needle to take out the medial portion of this lesion. Then you have to ask yourself what's above and below lesion. Below it, we're running out of tumor. Above it, we still have a lot of tumor. So this more lateral needle, I'm going to bias a little higher so it'll fall into this plane. So we're going to run the argon cycle on probe 2 now. That noise you hear is the gas escaping from the machine. That's an important noise to know that things are going well. If you put your hand down there, you'll actually feel the flow of the gas. Both gases vent from the machine and you can feel it coming out. Got this ice ball forming already. What's our time, Michelle?
30, approaching 30 seconds.
So 30 seconds is a good time. We've got a good probe. Let's hit thaw just to get the ice ball off. So I'm going to make a little nick with an 11 blade, just cephalic to the marker needle that I have in place. And that's just enough to let the probe in. I want to parallel the guide needle as best I can. And again, I'm not going to commit the full depth. We're going to take a look and adjust. These needles or these probes, I should say, are stiff and very, very maneuverable. This is a handy little device that helps tremendously in trailing the cords. The secret with this device is to bring your probe into axis. Here it's tipped cephalically, so if I just pull a little bit, and Michelle can help me, it's perpendicular now, and when we take our scan, we'll see the whole needle. Moreover, we're using general anesthesia. We don't use general anesthesia because it hurts, because freezing really doesn't hurt. And if you have patients that can't go under, you can do this with just conscious sedation. But GA is wonderful. You know, our anesthesiologists come over, help us with these guys. These are kind of long procedures. I think if he's laying here, he'd have a hard time laying still. Moreover, to me, the most important thing is apnea. When we take our pictures, we always have apnea. The kidneys move up and down, obviously, with respiration. With anesthesia, it stops at the same place each time. Very, very precise. It allows us to really lay these probes in where we need them. So let's take a set of 3 right there and see how we're doing. So the probe's in place now. That's pretty optimal. I'll advance a couple of millimeters just to center it. The active parts of the probe you can see. Michelle, go to spine or vertebral. A different window here. You can see the bright spots on the probe. That's the active gate. So I can advance that a little bit, and that'll be perfectly centered. Go back then, please, Michelle. We just have to figure out where our next probe is going to be. I think I'd like it a little lower. This guide needle here, the more lateral guide needle, is good. We can make that work, and we'll put our second probe in at that level. So I'm going to advance this probe just a couple of millimeters. We have a stick option here. We could run argon through this and stick it. The Endocare will suggest that, but if you've got gravity working for you, I haven't found that necessary, and it's a way to preserve your gas, so I don't bother with the stick mode. I'm going to remove this marker needle, make a little nick with the 11 blade, and we'll use the second probe that we've already tested. I should say that as you're beginning this procedure, it's probably easier to test probes one at a time as you need them. That way they're not in your way. And that's certainly, you can see, keeps things cleaner for you and one less thing to think about. So I'm looking back at the reference screen. I think this probe needs to be a little steeper than the guide needle was. So I'll advance it in. And again, fully expecting to have to readjust this. And we'll take advantage of this wonderful little holder over here. So this is a good example of the probe being off axis. We won't have any problem fixing that, but it's not the plane I intended, obviously. I'll just pull it back and redirect it. Go to the other window, Michelle, the abdomen window, and you can see the tumor. Again, as we get more and more probes in, you get more and more metal artifact. The utility of apnea and the absence of motion becomes more and more apparent. I really recommend, if you can get GA for these cases, that you use them. So we'll reposition this into a slightly more steep projection. I'm going to pull it back. And again, not commit too deeply, but enough hopefully to hold the probe. You can see it settles back. Maybe give it another. So here's the second probe, partially readjusted. I think it still has to go lateral a little bit. When you look at where you want your probes, this probe will treat the medial aspect of the lesion. And then you want to ask yourself what's above and below it. Again, on this next lowest cut and this next lowest cut, it looks like we're running out of tumor. So this will be a little lower. So certainly we're going to take care of the lower part of this tumor. This should take care of the inside of the tumor. This should take care of the outside of the tumor. So we've got 2/3 of the tumor covered with these two probes, I believe. So probe 2 is in place now. I'm going to just advance it to seat it at its depth. You kind of get the idea of depth from the probe that you've previously set. So now I believe that we've treated the inside of the lesion, the outside of the lesion, and the lower part of the lesion. I'll place a marker needle just roughly here again to check out the upper part of the lesion. So we'll center on these probes, and instead of doing 3 cuts, we'll do 5 cuts to make sure that we get a broader view of what's going on and to make sure we evaluate where that little pink guide needle is going to be. So here we are, we're going to go through the lesion. This is the original guiding needle from the biopsy, which is at the bottom of the lesion at this point. As we come up, we start to get into the 2 probes which are in place. They look side by side, but at the skin level they're off a few millimeters, as hoped for, staggered. That's partial volume. You know, CT will show things in the same plane. And as we continue up towards the top of the lesion, we've got our marker needle in place, and above that there's no tumor. So I think if we are able to put a probe here, we'll probably cover the whole lesion. The one part that I'm a little concerned about is the lower and medial aspect of this lesion. When I make plans for these procedures, I'm always willing to change them. Where the probes end up and where you want them to end up are not always exactly the same thing. And since you're treating cancer, I always assume that these are cancer. Putting an extra probe in at the end of the procedure that you weren't planning on, if you think of it, do it, because you don't want a recurrence. You don't want to leave it untreated. It's a lot of work for everybody to get here and put these probes in. It's expensive. So if you're thinking extra probe, do it. So this is our 3rd probe. One phenomenon that happens as you put probes in, one gets in the way of the other. So one of the reasons to use a long probe is so that the handle will stand above the others and it won't be in your way. This is in the 3rd slot over there, so with these stickers I'll mark it number 3. Michelle, let's test it. So we're going to run a 90-second helium cycle. This thing on my head, by the way, are not loops, not a light, it's a GoPro. So we've switched to the argon cycle after the 90-second thaw, and we should see an ice ball develop here, again looking for bubbles. We'd like to see it minus 20 by 20 seconds. 30 seconds. So at 30 seconds, there's no bubbles. The ice is not extended up the shaft. That's another safety feature. This ice ball is kind of small because this is a long probe. The smaller probes, the shorter probes, and the probes with lesser diameter are very efficient. They get big and cold quickly. So let's go to thaw. So even though the ice ball is gone, we're going to continue to run the helium cycle, because if you don't, you take it out, it'll just freeze again. Where our marking needle was, that turned out to be just the right spot. Again, you don't get too locked up in what you want and what is. You just make it what is, or what it needs to be. I'm going to go parallel to these probes because that's what's called for. You don't want to pull out your long probe early on, because you have to commit a lot of this probe just to get it in the gantry. So it's your 3rd and 4th probes that typically is called for. How am I doing there with the angle, Michelle? Does that look good? Okay. All right, let's do a set on that top needle, thanks. So the 3rd probe was placed, and this is its skin entry on the upper part, and it's descending. I didn't place it in a descending way, but it is descending. We'll go back out there and I'll show you what's happened. So what's happened is the probe itself has been pulled or deflected so that it's descending. In other words, this needle is off axis, just simply pulled. These are rigid instruments, and you have to pay attention to that. So when I left it, it was straight up and down. the cord was hitting the gantry, so we bent the cord, and that changed the axis. So with that in mind, I'll pull this back, make sure that I pass it parallel. By parallel, I mean parallel to the other two probes. Now we'll take a look and see. This is back in axis. It's in there far enough that it's secure, but not into the tumor yet, I think. So after it's replaced, it's better, but we still have work to do. This needs to be more lateral, and it needs to be slightly higher. So I'll pull it back, tip it quite a bit lateral, slightly higher, and then re-advance. And that looks like it caught in that more lateral projection, but we'll have to take the pictures to find out. So this is ideal. I'll tip it slightly more lateral, but all we really need to do is advance it. If you want to bias, if you don't want to be in the center of something, you want to be closer to the parenchyma of the kidney, because that's a warming source, whereas the lateral aspect won't have the heat of the kidney, and it's easier to freeze. So this is the upper probe. It's now in place, well centered. I'm probably advanced at a millimeter or a couple of millimeters, and you can see the next stop above that is a little bit of tumor. There won't be any tumor above that, so certainly we've treated the upper part of the tumor. Now the only question is, have we treated the medial part of the tumor? So we're going to do a set of pictures through the entire set. So these are the last set of images through the whole of the lesion in both probes. This is the top of the lesion with tumor. Next cut down, we have a nicely centered cryo probe. Here, again, the active gate is from here to here. Parenthetically, it's interesting to note that the renal lesions remain low attenuating for a really long time. I think most of us don't really appreciate that because in the diagnostic realm we never scan so late. But if you have trouble seeing a lesion, it's not like it's not like a hepatoma that's going to wink at you and go away. These stay conspicuous for a really long time, which is just fortunate. As we come to the next cut, a couple of lesions, a couple of probes, and again these are offset, one above the other a little bit. The concern here is, what is the distance to this medial edge? It's 14 millimeters from here to here. If this were a single probe, that wouldn't work, because you get a 24 millimeter wide lethal ice ball, 12 on each side. But since there's two probes here, that will almost certainly work. There's a third probe just above it. 1 plus 1 is 3 when it comes to cryo probes. And as we continue down towards the bottom of this lesion, again, we go from probe to lesion to almost no lesion. I think that if we just froze these, we would be successful. But again, I'll heed my own advice. You know, this is cancer, and it's just one more probe. It's a little bit more time, but we really do want to do the best thing for this guy and make sure we get this medial lesion. So I'm going to put a probe right through here. I'm not worried about the outer part. And again, I wanted to tell you guys that you don't have to have all your probes parallel, not by any stretch of the imagination. You could come in this direction, taking advantage of the long axis. But the problem with that is you would have ice out to the body wall. One of the issues with planning your ice balls is to realize the length of these ice balls is greater than their width. You know, these are eggs, they're not circles. So when you plan your cases, always make sure you can do something with the back end of the ice. So I'm going to put a marking needle down here and take a picture and then place another probe. So we've got our 4 probes in place now. I just want to mention something about the stick mode. The stick mode is an argon cycle. It's a brief cycle. When it gets down to -4 degrees, the argon will turn on briefly enough to keep it negative and keep it stuck or frozen in place. I'm not using the stick cycle in this case because the probes are deep and I have gravity working for me. But if they were superficial or the probes were this way, I would use the stick cycle. So after some manipulation, here's the fourth probe in the caudal aspect of the lesion. That's optimal. Below it, there's no more tumor, so let's freeze. So Michelle is going to activate probe 1 and hit the freeze button, activate probe 2, hit the freeze button, so on and so forth until she gets all 4 in the freeze mode. So I'm going to go ahead and remove the guide needle. I haven't removed it to this point with the thought that maybe if I pulled it out, the lesion would bleed. I don't think that would happen. Again, you want to make sure that you reinsert your stylet so you're not pulling a hollow needle out of the tumor. It's interesting to me that we ended up with 4 probes. I'm really happy with the way they're placed. We could have done this case with 2 probes had the axis been different. Most of these lesions, virtually all of these above 2 centimeters, have a long axis. And again, your ice has a long axis. So if you can work your probe down the long axis, if the long axis were in this direction on this case, we could have just put 2 probes down that long axis and we'd be done. So just the fact that it's like this instead of like this cost us a lot of time and 2 probes, but that's what it called for. It's possible we could have done it with 3, but once you have 2 probes in the middle of a lesion, you're pretty much going to be committed to having 2 probes on the top and bottom of the lesion as well. So we're in the freeze mode now. We're going to see a few things. Frost will develop on the outside of these. That's not abnormal. The typical freeze cycle is 10 minutes. I like to look at whatever half of whatever cycle that I think we're going to use. So we'll take a set of pictures at 5 minutes. With this many probes, we may in fact limit our freeze cycle to 8 minutes. But we'll look at 5 and see how we're doing. This is after a 5-minute freeze cycle. We're just beginning to get into the ice ball, and as we page down through here, here's our bottom probe, and you can see the ice ball developing around it. That's the nice thing with cryo. It's very purposeful in that you can see the ice ball and monitor your effect. We've got liver here, but it's going to be safe. The ice only goes forward about 5 millimeters. And here, with less metal artifact, we can see the extent of the ice again, starting to incur into the kidney. Now, realize that the lethal zone is 3 to 5 millimeters inside. Nice thing about cryo, again, is this interface right here is just ice. It's not lethal, it's 0 degrees. 3 to 5 millimeters inside that is minus 20, and for kidney, that's lethal. And as we continue down, we're through the ice ball. A typical cycle is 10-minute freeze, 8-minute stick thaw, 10-minute freeze, but really you monitor the ice ball and you're done when you're done. I'm not beyond at all extending a freeze for 12 to 15 minutes, and I'm not also opposed to stopping it at 6 to 8 minutes. Here we have no reason not to go the full 10 minutes. It's just going to be a bigger ice ball. I'm not worried about any adjacent structures. If I were, I would probably abbreviate it. But again, this liver's fine here. So here are monitors telling us how we're doing. It's important to keep an eye on these. Each probe can be changed in its percentage of efficiency. I virtually always run them at 100%, but let's say probe 4 was close to the colon. I could turn probe 4 down in its terms of efficiency to 50%, or I could turn it off completely. So in that way you have the ability to actually shape your ice ball. You like to see these things running in the minus 130, 140 range. The probes which are closer to the parenchyma, the heated parenchyma of the kidney, will tend to be warmer. But again, with 4 probes, it's an overwhelming amount of ice power, and they're all going to run about the same efficiency and the same temperature. This temperature, I believe, is back at the hub of the catheter where the thermocouple is, it's even colder at the tip. So we froze for 10 minutes. It's now on stick. All the probes are on stick thaw. These images were taken shortly thereafter, like maybe 10 minutes and 20 seconds. And again, we'll see how the ice ball has enlarged in the 5 minutes since we first checked it. And I really like this medial margin here that we've achieved. I'm not at all concerned about freezing into calyces. We're not going to here, but you can absolutely freeze calyces. A pig model, you can stick your probe in a calyx and freeze it, and they'll repair without a urinoma. You don't want to do that. That's another reason to give contrast, by the way, because you can watch your calyces for a long time. Coming up here, you can see this beautiful ice ball that we've got. We've definitely killed this tumor. And here's that sort of extra probe that we put in. I don't regret that at all. So these cords have all fallen into a nice pattern here. That's the responsibility of our blue gatherer. They're jacked into the machine here. This, I want to point out, is our vent holes. When the machine is running, you'll hear gas coming out. If you put your hand here, you'll feel gas coming out. That's normal. Argon and helium, of course, are both inert and not harmful. But that's a normal thing. When you first start doing these, you might think you've got an air leak under here, and that's actually what you're looking for. That noise we just heard was the stick freeze activating one of the probes or two of the probes. Got down to -4 degrees, so the argon cycle is running again. There's two more. That's keeping them stuck in place. So during the thaw cycle, they won't shift at all. The thaw cycle, I think of, and I think it's conventional to think of it about 80% of your freeze cycle. So if a 10-minute freeze cycle, an 8-minute thaw cycle is what we're going for here. And then the second freeze cycle follows. So the stick thaw is over, the 8-minute stick thaw is over, and Michelle has started the second cycle, which I suspect will be shorter than the first cycle because even though we've been thawing, we're starting in a cold substrate, and especially with multiple probes in, I find that the second cycle is usually a couple of minutes shorter than the first cycle. I'm expecting 8 minutes, so we'll look at 4 minutes instead of 5 minutes, and if I want to go beyond 8 minutes, I certainly can, but we're just going to keep a closer eye on it because it's going to be a very big, very intense ice ball here. So here's the 4 minutes of the second freeze, and again the bottom of the ice ball here. As we're coming up, we're going to see a larger, more defined ice ball than previously, and I think we'll stop this at 8 minutes and have a fine result. I'd like to make a point about the tip of the ice probe. You do extend 8 to 10 millimeters of ice off the tip of this probe, but it's only 1 millimeter to 3 millimeters lethal. So when you place these probes, you have to put them up and just through your target. It's not sufficient to leave them shy of the target because the ice going forward is mostly just ice, not lethal. That's a nice thing to know because the tip of the probe is very reliable where the ice is going to be. If you're worried about a structure, say this calyx, and you wanted to freeze it, you would want to bring your probe in this direction, put the tip of your probe at a distance where you're sure that the ice going forward wouldn't harm it. The ice laterally is more difficult to predict and monitor. So that's just one more trick, one more thing to think about when you're placing these probes is you got to get the tip through your target. And if you have something to worry about, you want to point your probe directly at it if possible. So our second freeze is complete at 8 minutes. We'll go to the thaw cycle now, just a straight helium cycle. And when the temperature of each probe is about 20 degrees above centigrade, we'll pop them out and do our final set of pictures and see how we've done. So the thaw cycle is complete. All of these probes are above 15, 20 degrees above zero. Rocking the probe, that one's still stuck in place. You can feel them release and pop from the ice ball. This one's ready to come out. Very simply draws right out. Sometimes you'll feel a pop and a release. Sometimes the ice will hold the probe even though the temperature indicates that you should pull them out. What we do is we turn off the stick at this point just to stop the helium cycle, and we just give these a twist so as to safely manage these probes. And we can bury these in the sharps container. So this guy's got 4 little nicks in his back, which we can cover with a single dressing. He'll spend the night in the hospital for observation and go home tomorrow with very little, if any, discomfort. Many times the next day people go, "Are you sure you did something?" But I do warn them that in a few days, as the healing sets up, paradoxically they might get a little sore. That's ibuprofen type sore. I tell them not pain. And it's very easily managed. But again, if it doesn't hurt the first day, it might hurt day 3, 4, or 5 as the healing and inflammation sets up. Let's go take our final set of pictures here and see how we did. So here's the final set of pictures after we've removed the cryo probes, just moments afterwards. And as we come up, we can see the remnants of the ice ball. It's amazing how quickly they melt at 98 degrees body heat. Here you can see the remnants of the tumor. Oftentimes at this point you can see very nice demarcation. This is just the defect in the ice, that's why there's air, because this is still ice. This is just absent where the probe was. Looks great, there's no bleeding. People talk about bleeding as a complication of cryo. It's very, very rare. I've done a couple of hundred renal cryo cases, and I've had 2 guys that bled significantly. One required a 1-unit transfusion, the other a 2-unit transfusion. People will bleed afterwards, but surprisingly it's uncommon, and it tends to be minimal. Depending upon how much you bleed afterwards is also how sore you'll be afterwards. If you don't bleed, you won't be sore the next day at all. If you do bleed, you'll be sore like if you had a renal biopsy. And that's pretty impressive, I think, that this technology is really so safe. Just wanted to point out one of the most remarkable things about this procedure in my mind is this guy just had a renal tumor taken care of, almost certainly a malignancy, and this is what he's left with. He's got 4 little puncture marks. If you had a big Band-Aid, you could cover it with a Band-Aid. And this is not lost on the patients. Our greatest referral source are urologists. This is also not lost on the urologists. They've largely adopted this methodology for their patients with small renal masses, and even people with large renal masses who are poor operative candidates. So again, good luck going forward with this modality. Good luck.